I want to thank the organizer, obviously, for this wonderful opportunity to share a little bit about our work with you. Obviously, Dr. Narayan is a very hard act to follow, but I hope that some of the things that I'll talk about will resonate the themes that he had already spoke about. So Autism Speak Public Health Science goal is pretty straightforward. We want to deliver innovative family-centered programs and policies, solutions that are relevant, responsive to the stakeholder priorities, and is equity-focused, feasible. We want to make sure it's realistic, efficient, effective, of course, evidence-based, and just as importantly, sustainable, that can be integrated into existing systems of care. At the risk of oversimplification, our experience has been that these are some of the ingredients that are necessary in order to achieve these objectives. Certainly, you want to have the political will that will provide the sustainability component, integration to system. But for policymakers to have that kind of make that kind of move or make that kind of decision, it's important to have evidence and, of course, feasible and effective tools. And finally, and this is, I think, where our focus has mainly been, a lot of our energy has been expended on, is engaging and empowering stakeholders. We do this through a vehicle at Autism Speaks called Global Autism Public Health Initiative, and it's a global collaboration to enhance ASD research, practice, and policy. We do this by supporting local leaders to address local priorities using locally customized solutions. And we work in the areas of public and professional awareness, advocacy, public health research and tool development, and of course, service and policy development, dissemination, and implementation. A big part of this program is actually our Advocacy Leadership Network, which I will tell you a little bit more about. But currently, the GAF initiative is in over 70 countries, where we play a technical advisory role to many government, typically at the ministerial level. But what really powers the work that we do are the families, are the advocates on the ground. And the Advocacy Leadership Networks are members that are respected local leaders with records of innovation and facilitating change. They are self-advocates, caregivers, professionals, policymakers, friends, and families. We stay continuously in contact through social media. We have annual meetings to facilitate knowledge exchange and transfer and collaboration. And we also collaborate in high impact network collaboration. For example, the UN resolution that Simon Hussein and the mission of Bangladesh led at the United Nations. We had members of this network advocating for the endorsement of the resolution at their respective countries. As of last year, there's 52 countries involved in the Advocacy Leadership Network, and there's a picture of who they are. And we bring them together, like I said, every 2 years to share information, exchange knowledge, and plot our next move. And this is the meeting that took place in Washington, D.C. last year. And what I love about this picture is really the pure diversity that you see in terms of geographical distribution, religion, age, and religious persuasion. So the principal work that we do is really with these group of individuals is community-based participatory research, is where we involve stakeholders as co-investigator. The feature is obviously complement highly controlled academic research. We focus on practice. We involve community stakeholders, especially end user, in prioritization of research questions, as well as design and implementation of the study. And most importantly, we share outcome with community participants and support their use to inform policy development, implementation, and resource allocation. I'll give you a couple examples of where we engage community in these meaningful ways. The first is what we call the Caregiver Needs Survey. I think for those who work in autism is familiar with the fact that one of the things I derive great joys in doing is talk to families. Families, especially caregivers, often enjoy telling a story of their journey. And often embedded in this journey, these stories and these narratives are information that are important for us to understand the challenge that they face on a daily basis. And we want to try to find a way to systematically capture these narratives and try to make them into data that can be shared with policymakers and other stakeholders. Now, obviously, this kind of services research or stakeholder research has been done previously. Most of it has been done in high-income country, even though recently more has been done in low and middle-income countries. So we're interested in knowing what does autism look like in those contexts. What type of services and supporters are available to the families? And what does a parent or caregiver's biggest needs and concerns? How does our country compare to other communities and countries? And what does the data tell us about where we are and where we want to be? In other words, our priorities. The methods it was a team effort. We actually developed these with family members and other stakeholders in the community. Remember, many of these communities, this kind of information had never been available, and their challenges and their issues has been largely blind to the policymakers. So we actually took items from existing surveys, domains including respondent characteristics, child characteristics, services encountered, and the caregiver needs and perceptions. Sampling is really a sampling convenience, because in many places it's very hard to get a population-based sample. But we use the social network among the families to disseminate and implement this study. And we collect the information and help them do the analysis. And we have several of these attempts now, these projects now all over the world. This is one example that's published from the Southeast European region. And there's 5 countries involved. And this is one type, it's an example of, I'm sorry, I can't read it very well here, but it's an example of the data that we're able to collect. And the top box really talks about the kind of services that many of these families have encountered. What is notable is that for some of these countries, the predominant service is actually speech-language therapy rather than behavioral intervention. And of course, in most of these countries in Southeast European region, it's a psychiatrist and psychologist that are responsible for their care. So currently, in addition to what we have published in the Southeast European region, there's a project that we're writing up right now for submission in Latin American region that has almost 3,000 families involved. Similarly, we're starting to use this tool in some countries like Serbia to inform policy development. Even though this is extraordinarily small sample size, it's actually been used in the current process in Serbia to develop new policies and program for our community. The second example I want to share with you is a caregiver skill training that Autism Speaks developed at WHO. It's really based on some of the seminal works that's been done in public health, research in mental health specifically. I think some of you may be familiar with Atif Rahman's seminal work with lady health workers in Pakistan in treating maternal depression. The idea that you can use task shifting or task sharing, the redistribution of tasks that are historically assigned to specialists to non-specialists is really at the core of this strategy. Dr. Rahman and his colleagues were able to actually do a similar study in autism spectrum disorder in India and Pakistan several years ago. This was published in Lancet in 2015, where they actually demonstrate that you can effectively teach intervention-naive non-specialists, including parents, on the evidence-based intervention, and you achieve results as good and sometimes better than when it's delivered by professionals. And the reason is because many of these families, many of these non-specialists who live in the community that are delivering these interventions share the same lived experiences as those patient families or those families in need, and they're able to leverage that experience to enhance the intervention. So this kind of work that has really informed the development of the Caregiver Skills Training Program is formerly called the Parent Skills Training Program. It has just been renamed last week or so, a couple of weeks ago. It's a collaboration between Autism Speak and WHO, and is part of the WHO Mental Image Gap Action Package. The innovation for this particular package is really, again, the engagement of the stakeholders, the engagement of the family stakeholders. In order to address the capacity issue WHO Autism Speak trainers actually train master trainers in certain country. These are specialists who then train a group or a cadre of non-specialists or facilitators. These are individuals who live in the community, and then they teach the program to the caregiver, who then deliver intervention to the children. The other aspect I want to highlight is the development process as protocol. As in many WHO products, involves extensive expert reviews and internal reviews. But in this process, we also brought in family members, caregivers, people in the front line to Geneva in 2015 to take a look at the initial package and give us the feedback whether or not these are actually meaningful to them and feasible and relevant. So right now, this package is being implemented worldwide. We have about 30 countries at this point that are doing this work at various stages of development. And there are 3 RCT sites, including Pakistan, Italy, and China, that was soon to be launched. So in conclusion, family stakeholders have led the way in our autism advocacy, research, and service development by engaging and empowering family stakeholders. We have development strategies and effective tools to begin iterative learning implementation process, to establish evidence-based services, even the most challenging settings. The CST, for example, has been implemented in rural Ethiopia, Syrian refugee camps, and underserved urban areas. In order to reduce knowledge and outcome disparity, inclusion of historically underserved population advocacy, research, and services development implementation is both a necessity and the right thing to do. Thank you.